So hi friends, today we are going to talk about very important liver function test. बहुत सारे clinical cases, cards, MCQs are going to come on to it. So let's understand this topic through some questions. Now you have a 24-year-old uh, person who presents to the outpatient department with yellow discoloration of the eyes and not associated with any other complaint including pruritus or clay colored stools. Now first please understand the patient is having yellowish discoloration. So what is that? It is jaundice. So jaundice is what? It is a yellowish discoloration of the sclera or of the mucous membranes or of the palms and soles. Okay, so why only sclera do we have this? Because two things that can be asked to you is that it has a white, it provides you a white background through which you can see the yellowish discoloration, and another important thing is that it has a lot of elastic tissue that helps bind the bilirubin. So that is why you have this prominent yellowish discoloration on the sclera. Now next part of it is that if you see the reports, the total bilirubin is 7, direct is 0.7, and the enzymes, all of them are pretty normal. So what does it say? First you have to see the bilirubin values. टोटल बिल इज रेस, दैट इज वाई वी हैव जॉन्डिस. ठीक है, जॉन्डिस तो इसी के लिए है. नेक्स्ट द डायरेक्ट बिल इज 0.7. सो प्लीज अंडरस्टैंड दैट यू call it as direct bilirubinemia when the bilirubin is or the direct bilirubin is more than 50% of the total bilirubin. It is not here, so there is no direct bilirubinemia. And next is it is indirect bilirubinemia when the indirect bilirubin is more than 85% of the total bilirubin, which is going to be here because you calculate the indirect bilirubin by minusing total bill minus direct bill. So that is how you get indirect. So you have in this patient jaundice, which is because of the indirect hyperbilirubinemia, and all of these liver enzymes are pretty normal. The next part which is given is that the hemoglobin is reduced, that the patient is having anemia, and the smear is showing the presence of the bite cells. We are not going to discuss what does this PS indicate. It says, of course, if a bite cell is mentioned, that we are talking about G6PD deficiency, but what is happening in this kind of hemolysis is what we are going to discuss further. So now you had just seen that the patient is having jaundice because of hemolysis which is there, or hemolytic anemia which is there. So there is excess of the bilirubin production, and which type of bilirubin? That is the unconjugated bilirubin. This can happen apart from hemolytic anemia. You have ineffective erythropoiesis, thalassemia, megaloblastic anemia, or resorption of a hematoma anywhere else in your body. This bilirubin or the unconjugated bilirubin, please mind you, it is water insoluble. It is not going to be soluble in water, and as a result you will not find this bilirubin in urine. So your urine color is going to be absolutely normal. First part. Second, since because there is lot of unconjugated bilirubin, a lot of this unconjugated bilirubin is going inside the liver to get conjugated. Hence you will have more of the urine urobilinogen, because urobilinogen is there present in the urine. So there would not be any urine, there would not be any bilirubin in the urine, no bilirubin in the urine, but the bilirubin is increased in the serum. In your blood, bilirubin is increased, but not in the urine. And in the urine, you will have increased urobilinogen, and because of that, the color of the urine is going to remain normal, or the pale straw colored urine, which is because of urobilinogen, that is going to remain the same. So let us understand what is happening in hemolytic anemia, or whenever the RBCs are aging or they are getting lysed. This hemoglobin is going to release heme plus globin, okay, as all of us know. So this heme is going to first get oxidized by heme oxygenase to form biliverdin, and when it is exposed to light in the presence of biliverdin reductase, it is going to get converted into unconjugated bilirubin. So this is how the story till far with unconjugated bilirubin. When till here your liver is not involved and something is happening before the liver. तो अब यहाँ पे क्या हो रहा है? Because of this unconjugated bilirubinemia, apart from that, in hemolysis you will have other things like, because of intravascular hemolysis there can be increased LDH, and heptoglobin may be decreased because all of this bilirubin is binding to the free heptoglobin in the blood, and this heptoglobin levels are going to go down. Now next what happens is you have to see that how do you calculate the estimate the serum bilirubin levels in your blood. Please remember Vandenberg reaction. This is very important. बहुत सारे MCQs may they do ask you and you should be knowing what is this. So this is also known as the DISO method, and this method is a principle for the dipstick test also that you do in your labs. First thing. Second thing, why direct bilirubinemia is called, why direct bilirubin is called direct क्यों बोलते हैं? Because direct bilirubin you can measure directly by a Vandenberg reaction. What you take? You take your bilirubin or your blood sample, you add a DISO reagent like sulfacenylic acid, and it will form a blue color directly without adding any activator. But if you add some activator, accelerator to this reaction and then measure it spectrophotometrically, you are measuring total bilirubin. तो बात समझ आए? Directly you are measuring direct bilirubin. If you add some accelerator, you are measuring total bilirubin. When you subtract, you get indirect bill. So indirect bill is indirect because the calculation is indirect. You are not getting it directly through the reaction. Okay, so this Vandenberg reaction should be very clear what we are doing, and it is forming a blue colored compound which you are measuring by spectrophotometry at 540 nanometer. Now what are the tests that you can do in your urine? That is also very frequently asked in your exams or in your practical vivas. Remember it through a trick. You have Mellin test 3, then you have Lugol's iodine test 4, you have foam test FF for 5, dipstick we have already talked about, and then you have Foch's test, that is also for and 5. Why am I saying so? In Mellin test you are taking 3 ml of urine and 3 ml of concentrated HNO3, and you see the gradation of the color changes which are happening. Some of these tests are very theoretical. Foch's, of course, you know that it is being given to you, and foam test is also being asked. Lugol's iodine, 4 ml urine, 4 ml Lugol's iodine, and you get a green color. So 3, 4 and 5. Foam test, 5 ml urine and you get a yellow color foam. If bilirubin is present, you get a yellow color foam. Then dipstick test is based on DISO method only that we have discussed earlier. And Foch's test is you are taking 5 ml urine, then you add 2.5 ml of barium chloride. It forms a sulfate complex with the bilirubin. Now you have to filter this. When you filter, you get only this complex on the filter paper, and then you add a drop of Foch's reagent, which is a compound of trichloroacetic acid, ferric chloride and distilled water, and then it gives you a blue-green color. This test is asked sometimes in your practical exams. You have to perform it. It is a pretty simple test that you can do on your own. Now, the next history says that you have a 35-year-old male with yellow discoloration of eyes and skin for 2 weeks with a dark colored urine, loss of appetite, fatigue, malaise, nausea, vomiting. Firstly, you have a dark color urine. So dark color urine है, that means some direct bill is present. ठीक है, direct bilirubin present है, that is why the color is changing, because indirect bill, as we just said, is not excreted in urine. If urine color is changing, that is because of direct bill. Now direct bill can be present alone if there is obstructions, so it is a post-hepatic jaundice, or it can be present in a association or in combination with unconjugated bill also. That is what happens in the hepatic jaundice, because in hepatic jaundice you have a mixed pattern. You have direct bill also and indirect bill also. Plus the patient is giving some symptoms of nausea, vomiting and fatigue, which are favoring more towards some hepatic cause, plus a recent history of travel, that is again pointing towards the hepatic cause. But I am not going to make my diagnosis now. I am going to see the bilirubin level. So the total bill is raised. See, direct and indirect, nothing is pointing towards one thing alone. For direct we said it should be more than 50%, but here it is less than that, and for indirect we have said more than 85%. Here also it is less than that. So it's a combination of where both direct and indirect bill are raising. Next I came to the liver enzymes. So liver enzymes are also raised. AST, ALT, ALP, all of them are raised. So when the liver enzymes are raised, I am pretty sure of a hepatic cause. Urine में bilirubin is present. कौन सा bilirubin is present? It is always conjugated bilirubin. And urine urobilinogen is increased. Of course, it has to be increased. That is why because more of the conjugation and all of this is happening. So urine urobilinogen is going to be increased. Now, if I look at this hepatic causes ka table, we all know that there is some hepatitis or cirrhosis or any drug-induced liver injury. Where the liver is injured, you are going to have hepatocellular causes. Now, understand this pattern. Sometimes it is a very important pattern in your clinical histories which are given to you. Normal AST to ALT ratio is 0.7 to 1.4. When AST is more, that is the ratio is more than 2, it is suggestive of alcoholic hepatitis. But when the AST ALT is less than 1, that is the ALT is more, you have acute viral hepatitis. So you remember only one thing: when the AST is to ALT is more than 2, I am dealing with alcoholic hepatitis. And the normal values for both AST and ALT is 5 to 40 international unit, or some books also say 10 to 40 international units per liter. Important part, whenever there is cholestasis, when the jaundice is hepatocellular, happening because of hepatocytes, these enzymes are present in the mitochondrial or the microsomal membrane and the cytoplasmic membrane. So this is going to increase. But ALP is a clear-cut indicator of cholestasis, that there is some obstruction to the flow of bile. So when isolated ALP is increased, you have to think about cholestasis first. So that is why in post-hepatic jaundice, that is jaundice which is happening due to obstruction outside the liver, that could be because of gallstones, pancreatic carcinoma strictures, where you have absolutely an increase of conjugated, because conjugation to liver mein has already happened. Now conjugated bilirubin is going to increase. So conjugated bilirubin increase होता है तो क्या होता है? Your urine will have more of conjugated bilirubinemia. It is going to have less of stercobilinogen. That is why you have pale colored stool. You have pale colored stool because obstruction ho gaya. The urine stercobilinogen is not going to get deconjugated within the intestine, and that is why you have clay colored stools in your post-hepatic jaundice. So whenever you get this history, that means you are dealing with a post-hepatic jaundice. I have not covered obstructive jaundice ka history in here, but maybe in future videos we can have. So herein I have discussed more about direct and indirect bilirubinemia, how can you detect those tests in your urine and in your serum samples, and how you can differentiate between prehepatic and hepatic jaundice. That becomes a very, very important MCQ as well as a part of your urine examination cases.